Good morning and welcome everyone to this week's Inside APSAD webinar. And I guess very timely to be talking about APSAD, given that that conference is currently running virtually from Brisbane here and around the nation. So for any of you who are joining us this morning, who have ducked out of the APSAD conference to come and join us, thank you. You're very welcome. So I'd like to begin by paying my respects to the traditional owners of the land, coming to you here from Miagin in Brisbane, the lands of the Turrbal and Yagara people, and also extend that to the traditional owners of the lands on which we're all meeting today, our speaker who is coming to us from the Sunshine Coast, and also extend that respect to elders past, present and emerging, and to any First Nations people who are joining us in this webinar presentation this morning. So my name's James. I'm one of the clinical educators here with Insight. So it'll be my pleasure in a few moments to introduce our speaker. And just to let you know for our proceedings today that we will be inviting people to pop in chats, any questions or any comments into the chat box today, which at the end of our presentation from Mr. Chris Dawber, we will be able to engage in having a bit of a, I guess, opportunity for him to respond to anything that's been raised by our attendees today, which will be excellent. I do apologise in advance, though, if based on time, we don't get through all of that this morning. So without any further ado, I'd like to introduce Mr. Chris Dawber, who is the clinical nurse consultant and a psychotherapist who's based with the consultation liaison psychiatry and addiction team with the Sunshine Coast Hospital and Health Service. And a very important topic, Chris, really looking forward to this today because particularly as an allied health clinician myself, supervision has always been a huge part, I guess, of our training and our practice and, you know, the basic expectations of our work. So any models, any ways, any learning or an experience is something that I'm looking forward to. So thank you very much for joining us and for coming along. I'll hand over to you.
Thank you, James, and welcome everybody, and thank you for tuning in. Yes, I think clinical supervision is very topical at the moment, and particularly for nurses and midwives. And as a nurse, I've really appreciated my experience of clinical supervision, both individual and group. And I've, as a consultation liaison nurse, really become aware of how important this is for other branches of nursing and for my colleagues that work in the range of generalist areas. I'd like to point out that recently in 2019, there was a joint position statement which was released by the Australian College of Nurses, the Australian College of Midwives and the Australian College of Mental Health Nurses, which really ratified the importance of clinical supervision for all branches of nursing and put us on parity, I think, with all other professions that have had access to and I guess seen the benefits of supervision. Also in Queensland, in the last year, there's been the Office of the Chief Nurse and Midwifery Officer have released a Queensland position statement. And really, I think all nurses and midwives should be looking to access at least an hour of clinical supervision, of some form of clinical supervision per month. There are now a number of studies that point to the benefits of this. And my interest in clinical supervision really, though, grew from what I call, you know, practice-based evidence rather than evidence-based practice. As part of our role in consult liaison, we do try to focus on liaison-based activities that create an opportunity to build mental health awareness, build capacity and educate our colleagues on aspects of mental health and mental illness. Nursing and midwifery is an extremely rewarding profession in my experience, and I know many of my colleagues feel this way as well. And one of the most rewarding aspects of it is the connection that we're able to make and to convey care and compassion to those we work with, be they our patients, clients, consumers, and our colleagues. And with this interpersonal aspect, or what I call the craft of nursing, you know, there's a certain compassion, satisfaction, and reward for us. There's a sense of self-efficacy because we're able to make a meaningful connection with people. Unfortunately, sometimes this also brings with it a burden of emotional labour. We are often the ones that attend to the distress and the anxiety, the frustrations of our patients. Not only that, but I think that the system that we now work within, the health system, in its evolution as a business and its evolution in terms of a bureaucracy, in an attempt to provide checks and balances and to assure quality, inadvertently, we've actually provided further barriers and burdens for those of us, nurses and allied health and medical professionals, in terms of this aspect of healthcare, the interpersonal aspect of healthcare. And I think that for me, the reflective practice group movement, and I'm calling it a movement because in a way, in some way it is, you know, countercultural, is to try and reclaim and value and look at ways to promote and acknowledge that aspect of healthcare, the interpersonal aspect. So reflective practice groups give nurses and other healthcare providers an opportunity to tell their stories. It's about the connections we make and the impact that makes on us. We know that reflection has been espoused for a number of decades now as a very important professional development tool. And the two definitions that I provide here look at both the cognitive and intellectual, technical working through that can occur in reflecting on and reflecting in practice in terms of our learning, but there's also another element to it, and that is the emotional processing that can occur and the way that it can be transformative to reflect on difficult and challenging situations in a supportive setting, which allows you to make meaning and, I guess, further define yourself as a person within your role. In groups, this reflection can be amplified. And the idea for reflective practice groups came for me from education sessions that I provided as a consultation liaison nurse, where I would talk about aspects of anxiety and different symptoms of psychosis. And that was kind of interesting. It was conveying information, but often the most lively and useful parts of those presentations were when nurses would talk about their own experiences. And I realized that direct application of knowledge and the way that we could reframe and the way that we could help this processing both on an intellectual and emotional level was extremely helpful, probably more helpful. The other thing that I became aware of in doing the reflective practice in groups and starting to look at real-time case scenarios and aspects of mental health and mental illness was that it helped those present to gain a more, to become more aware of each other's ways of processing things and each other's difficulties with processing some things. And a byproduct that seemed to evolve from this was that there was not just an increased awareness, but an increased tolerance. And with that, an increased sense of cohesion within the workplace. It's interesting that in 2005, Sigma Theta Tau International, which is the International Honor Society of Nursing, promoted reflective practice as the most important professional development tool for our profession moving into that decade, and that it should be incorporated in all aspects of education, learning and practice. And certainly that's what I was finding incidentally at that time through my own experience. There are a number of different forms of clinical supervision. And I think it's very important, I want it to be known that I'm not saying that this reflective practice group model is any better or worse than any other model. I value many other models, the role development models, some of the discipline-specific models, some of the peer supervision models, and certainly this supervisory alliance model of Proctor's, that is all contributing something to what I'm now calling a clinical supervision community of practice, that there are different styles and different techniques and different methods that are useful in different applications. I personally believe there's a role for both individual and group supervision, and I undertake both on a monthly basis and value both. They give me similar benefits, but they also give me different benefits. Proctor Supervisory Alliance model spoke about 3 key elements from supervision. The first was what we learn from processing and talking in this reflective, supportive space. In reflective practice groups, I term that the wisdom of the group, that we can tap into the wisdom of the group. No individual holds a monopoly on the truth, and we enter into a dialectic which allows us to reach a shared understanding. At the end of the group, we don't say, well, you were right and you were wrong. We say, that's interesting. Let's go away and process this further. We also have a normative element, and traditionally, the normative element of clinical supervision has been viewed as the agenda of the organisation of management, the things that allow us to regulate practice, to ensure accountability, to look at how what we do measures against the benchmarks that are provided for us. For me, though, that normative element also means something, what is normal for a nurse working in ICU, or what is normal for an oncologist working in an outpatient clinic, or what is normal for a dietitian who works across a number of wards. And that normative element is not necessarily just about what the written rules and workplace guidelines and protocols are, but it's about the unwritten rules. It's about the law, L-O-R-E, as opposed to the law. And so for me, normative is a very important element of this type of reflective facilitative clinical supervision, because it allows us to check and moderate and learn. The third benefit, and one that I think a lot of the research has indicated that most nurses value the most, at least in the early stages of their clinical supervision journey, is the restorative and supportive benefit. That burden of emotional labour that I spoke about earlier can have some major impacts on us as people, the person within the nurse. And so providing an opportunity for nurses to process that and support each other with that is very, very important. I propose that reflective practice groups are a form of clinical supervision because I believe they meet all 3 of Proctor's proposed benefits. And I'm hoping in this presentation that I will convince you of that as well. At the moment, I think there are well over 50 reflective practice groups running through Southeast Queensland, well over. Tried to be conservative here on the Sunshine Coast where I work. We run over 30 groups. I support other health services and some private service providers in running groups as well, particularly in Metro South and in the Queensland Children's Health. Reflective practice groups run fortnightly or monthly, occasionally weekly, but I think fortnightly is a good frequency in the ward environment where it's not a closed group. You're not always going to get exactly the same people coming each time. Most of the groups are single profession, and that's because they've evolved from my interest in the nursing supervision area. But more and more, I'm starting and finding others starting multidisciplinary groups. So although they're mainly nursing, I run groups for medical officers and for allied health groups, as well as multidisciplinary teams. There is a training program that we run. We do have a workshop, which was a single-day workshop, which I'm now evolving into 2 to 3 days of workshops. But the real learning takes place in what we call an apprenticeship. So the apprenticeship is 6 to 12 months where trainee facilitators or prospective facilitators team up with experienced facilitators and learn the craft, once again, the craft of supervision in a group. And it is quite a complex craft, and it's a fairly sophisticated skill set. So it does take that time. We also have monthly supervision of supervision, so that those who are facilitating get an opportunity to come and learn from the wisdom of the meta group, the group of facilitators. But we also have real-time supervision that occurs in debriefs after each group's run. Where do these groups come from? This is a little bit crowded, but I want to acknowledge that there are two lineages here. What I've called the paternal, just in reference to Freud, the paternal or psychotherapy line, has come from the tradition of psychoanalysis and psychodynamic theory, and there's been some very profound influences there on my thinking, mainly from the object relations and self-psychology schools. But as an integrative psychotherapist, I've drawn on other areas. I really like this narrative approach and the way we tell yarns. On that note, I'd also like to acknowledge the influence of Indigenous brothers and sisters that we acknowledged at the beginning, in terms of the power of the yarning circle, where we sit and non-judgmentally listen to that person's truth. Contemporary influences at the moment in particular are the Brisbane Supergroup, which is my supervision group that I attend each month, and also the Tavistock Reflective Practice Research Network, where a number of like-minded clinicians and therapists come together periodically and talk via Zoom about the development of the reflective practice group model. On the maternal or nursing line, which I'm equally as proud of, and I'm a very proud nurse, I really want to acknowledge some of the influences in terms of reflective practice groups, particularly Platz's work and Dawn Freshwater, and the generosity of Simon Horton, who, although I've put him on that line, is actually a speech therapist, and some of my colleagues here who are still influential in the development of this model. The Tavistock Clinic started what they called reflective practice and team development groups, the work of Chris Scanlon and John Adlam, and now more recently Arabella Kurtz have proposed the name reflective practice as an alternative to clinical supervision in the UK within the National Health System, in an effort to try and distinguish itself from what was becoming, I guess, for me, a deviation from the true essence of what clinical supervision should be, more moving towards that normative and that almost managerial type of supervision. Their effort was to look at this as more of an intersubjective experience, the intersubjective therapeutic third and the interpersonal aspects of supervision that we've all chosen to focus on. In fact, Arabella Kurtz has written a book recently, which I will give a plug for. It's called How to Run Reflective Practice Groups, and it's based on her intersubjective model, which she is now calling the heads and hearts model. It's a term that really resonates with nurses, she finds. For a reflective practice group to be successful, we really need organisational systemic support. And this is so important that these negotiations occur early, and that it's not just in principle, but that nurses are allowed and enabled and encouraged to attend these groups, and that there is evidence for me now that where I've run groups for nurse managers, reflective practice groups, they actually also provide a very valuable support for the group by showing through their own actions that they value clinical supervision and reflective practice groups. So this kind of almost, yes, it's changing culture from a grassroots level. And once again, that's why I've decided to call this particular model a movement, the reflective practice group movement. It's so important that the facilitators that are involved in the groups or that are proposed to run the groups are seen as credible and perceived as impartial and unbiased by the group itself. And one of the key things in this particular model is that the prospective group, the staff members who form the prospective reflective practice group are involved from the early stages in making informed decisions about how, whether, how and when the group will proceed. And now this is, once again, counterintuitive for many of us working in health systems, where often there's an edict offered that, well, this has worked here, so we're all going to do it now. For me, it's about being respectful and compassionate and extending an invitation rather than providing an ultimatum. And so I'll often go and speak with nurses and say, look, you know, we've been doing these reflective practice groups. You guys seemed a bit stressed. Are you interested in this sort of thing? Well, what is a reflective practice group? What is a reflective practice group? We'll have this conversation, and then that'll evolve into some formal session. If you want, I can come to the staff meeting and do a presentation. Or if you've got an education session, let's talk a little bit about it. I might show a little bit of a presentation similar to this one, or show some video footage, which I'm going to show you later in this presentation, of nurses who've been involved in reflective practice groups. I'll say to them, if you've got friends in the other wards, why don't you just check, ask them to come and talk with me not there, so they can tell you what they really think. So over a period of time, I guess we develop this understanding, and then they say, look, you know, well, let's give it a go. So we'll just say, well, how about we do 3 months worth of groups or 6 months worth of groups? And if you like it, you can vote to keep going. So it'll be up to you. I think that this is an important point, that it's an obligation for our workplaces, for our organisations, to provide the opportunity for clinical supervision of any kind. But it should never be, in my opinion, an obligation or mandated for any individual clinician to attend a specific type of clinical supervision. It's like therapy. You need to find a person that you relate to, that you have a therapeutic alliance with, that you have trust in. And this is so important. And this is why one of the key points up there is voluntary participation, that we encourage, we invite, we give information, we rely on word of mouth, but we don't force. So as you can see, there's a bit of preparation that we want people who are coming to the groups to make an informed decision about it, and that we protect the space. So it's so important that part of that tangible support from management is that this is the reflective practice group space. We use that unless it's absolutely, we're unable, completely unable to make the space because of clinical acuity or staff shortages. We look at establishing clear group rules with the group, not imposing them, but sit down and say, look, what are the things that we need to do? And we have a template because we know that most groups are going to say the same sort of thing, and we sometimes rely on that, but the group makes that decision. The group defines its membership, and we allow the group and encourage the group, allows the wrong word, we encourage the group, invite the group to make the evaluation of each reflective practice group every 6 to 12 months. And during that process, we find out what they feel are benefits from it and what are some of the issues, and then whether or not they want it to continue. Ted White and Julie Winstanley published this paper, and this is something I wish I'd paid more attention to earlier on in this, because when I started to, as I said, this was practice-based evidence, I thought, well, people seem to be enjoying this. This is good. I'm going to keep doing it. Then, of course, I'm trying to think, well, how do I show that what I'm doing is actually worthwhile? You know, people can say that. Maybe they feel sorry for me, or maybe they like me, but I really wanted to look at how we can then provide some evidence for my practice. And so I think this is really important for any of you who are thinking of starting groups to refer to White and Winstanley's recommendations here, particularly those on recruitment and on education and preparation. So for me as a facilitator, the benefits of sitting in this circle are immense as well. I guess there's a parallel process. The type of compassion, satisfaction, and the rewards we get from delivering care and making meaningful contact with other human beings are amplified and are conveyed to me by the groups when I connect with them and we get to the performing stage, as Tuckner would say. We reach this level of deep and meaningful reflection where we're not just talking about our clinical practice, but we're talking about the underpinnings of that, the impacts it has on us, the people within the clinician, the impacts it has on those we work with, the impacts that we can have on the system we work within. So for me, there are tremendous benefits, but with that, there are also tremendous challenges. Sometimes in a similar type of parallel process, the frustrations and barriers that are experienced in the workplace are brought into the group. And as a facilitator, you have to really be reflective and mindful about how much of that you take on, because sometimes it can be directed at you. Just as we direct our frustrations at others, the reflective practice group becomes a microcosm of that. We use techniques that are based around reflection, some of them quite structured, like Rolf's technique or Bowd's or Kolb's reflective cycle, the Gibbs cycle, some of Schoen's model. One that I particularly like is the Atkins and Murphy 1993 model. And we use these frameworks to inform our interventions with the group. But what I've found is that as groups mature, they get to this performing stage, those kinds of structured reflective mechanisms are no longer necessary. And other researchers into reflective practice groups and action learning groups in the 1990s, Heath and Johns, both found that as groups become more mature and more confident, then they often discard those and go for a much more organic flavour. And I'd like to promote that reflective practice groups try to achieve that organic, interactive, intersubjective, interpersonal way of reflecting in clinical supervision as early as possible. These groups are process focused. As I said, as an integrative therapist, I value a number of different approaches. But what I do value are the common factors that make all approaches, I believe, more effective. That is the Therapeutic Alliance, the maintenance of hope, something of the way we use and integrate the techniques that inform our practice, but that we do it in a way which is more fluid and more organic. So the initial research was published in the International Journal of Mental Health Nursing back in 2013, and I did the pilot study. The initial article proposed the model, and then the pilot study showed that the nurses that participated, which in those prototype groups were a group of group practice midwives, a group of critical care nurses, and a group of chemotherapy oncology nurses. They all felt that they'd gained new clinical insights from the groups, that it had increased their self-awareness, improved quality of care and job confidence, and provided some restorative benefits as well. Later on, I did another study which was longitudinal over a 3-year period, looking at 2 groups, one in oncology and one in ICU, a fairly large cohort. And we found that whilst there were similarities and benefits, that each of those groups gained different benefits. Interestingly enough, the oncology nurses that were a fairly closed group of nurses that worked together frequently really got a lot of formative benefit out of the groups, whereas the ICU nurses that often sit one-on-one with their patients and didn't have that opportunity to come together very often gained a much more restorative benefit from the groups. Both were important and both were what those groups needed at the time I'm proposing. But at the end of that time, I realised that I was a hopeless researcher. Well, I'm not a hopeless researcher, but I didn't really know what I was doing. And like my practice-based evidence, I sort of fumbled my way through it and learned through bitter experience. Having said that, I learned some very valuable things, and I can now tell you that the frustrations that I found about the peer review process have now turned to be so valuable that the peer reviewers that have looked at my articles, our articles now, have just been so helpful and useful, and I really want to acknowledge them in this. This is the research team I've been working with recently from the Sunshine Coast University Hospital and from the University of the Sunshine Coast. And we've been working on trying to find evidence about the impact of reflective practice groups for nurses for the past 3 years now. And the first study we did really looked at compassion satisfaction, and we found that reflective practice group attendance was positively correlated with compassion satisfaction, but we couldn't predict reductions in burnout, secondary traumatic stress, or compassion satisfaction, which go under the umbrella of professional quality of life, above and beyond personal factors. The second part of that initial study then started to sort of tease this out a little bit. We found that there was a dose effect, that nurses that came to 6 to 18 groups, those that went to 1 to 6 groups, which was a majority of those in the first survey, didn't necessarily show significant benefits compared to those who hadn't been at all, because we had a control group in that study. But the second part showed that, well, those that had been to 6 to 18 groups actually showed significantly lower levels of inhibitory anxiety. And these are the types of anxieties that prevent us, I think, from using initiative and working to the scope of our practice. And they also showed that research also showed that there was a correlation. And I have to say correlation because we can't prove these things are causative, but they add to the body of evidence that lower intolerance to uncertainty, very important for nurses, particularly in these current times. We found then that those nurses who'd been to more than 18 groups, which means they've been coming for a couple of years. So there was this cumulative dose effect that they actually had significantly higher levels of compassion satisfaction. And not only that, this proposition from my original model that could have an osmotic effect on ward culture and create cohesion within the team was realised as well. However, what we found was the benefits, I was thinking that the osmosis may extend to those who choose not to come to the groups, that maybe that the benefits of awareness and tolerance were conveyed into the broader workplace, but that wasn't found to be the case, or we couldn't prove that was the case in this research. What we found, though, was that it was for the individual nurses that actually attended. So that cohort was 251 nurses. The next study involved a cohort of 192 nurses. What we found in this study was, once again, that there was a strong correlation between reflective practice groups that were seen to be effective or high quality. So previously we were talking about a dose effect, the amount of groups you went to. Now we're talking about a potency effect. How effective participants view the groups to be. When they go to the group and they go, that was a really good group, this is why it was good. And we use a tool called the Cseq, Clinical Supervision Evaluation Questionnaire, to assess the effectiveness of the group. That was developed by Horton et al. 2008. What we found was that there was those participants that found the groups to be of higher quality also demonstrated significantly greater personal and job resources. And this indirectly predicted, predicted is a psychology term that's used in statistical analysis of data. What I would say, so that's correct in its use there, but what I would say is that these increased personal and job resources were actually seen to be correlated with greater professional quality of life. Remember, I said before, quality of life was compassion satisfaction, burnout, and secondary traumatic stress. So what we started to realise, what we found in this study was that those nurses who really valued effective reflective practice groups had greater personal and job resources. Remember, in the first study, we couldn't distinguish increased compassion satisfaction from personal and job resources. Now we're trying to say, well, there's an indirect effect because actually those personal and job resources are enhanced, could be possibly enhanced by coming to reflective practice groups. I'll just go back one. There was some specific areas where this was noticeable, and that was in self-efficacy, autonomy, skill discretion, social support, and group cohesion. So the next study was a qualitative study, and I've presented this previously at the Australian College of Mental Health Nurses annual conference, national conference. So basically what we found is that, that there's this kind of algorithm or formula that we believe is important. Once again, slides are a bit busy, apologies for that. But if you look at the flow chart, that if groups are helped to determine the homogeneity of their membership and they're assisted and facilitated even at that beginning stage to be involved in and empowered in the process of forming the reflective practice group, and they are able to voluntarily participate in the process from an early stage, that they are able to move with the help of effective facilitation towards this level of self-disclosure, which is more than just talking about our work. It's talking about parts of our work that we're not happy with. It's about talking about parts of our work, things in our job that we've done wrong, or things that we're struggling with, or philosophical and ethical dilemmas that we're facing about end-of-life care, or about the way we impose treatment at times in mental health. And that through that process of self-disclosure in a supportive environment with a facilitator that's able to support and enable and encourage and work with the group, there's this sense of universality. Now, I want to qualify that word because it may mean different things to different people. For me, what universality means in this context is that those nurses and those allied health professionals and those doctors that become part of that group start to feel the sense of togetherness, of usness. Instead of feeling that they're alone sole practitioners, which many of us do feel, that we start to say, hang on, there's this sense of commonality, there's this sense of something that unites and binds us, and that's really, really important. And with that comes an increased awareness and an increased tolerance and an increased empathy. So the empathy is not just for our clients, it's for our colleagues, and it's for others as human beings. So this is really about this intersubjective, this interpersonal element of this type of supervision. And with that comes emotional respite, what Proctor calls the restorative benefits of group supervision. So from there, we've made this outrageous proposition, which is going to be controversial, but nonetheless, that what happens is that those who come to the groups may start to evaluate themselves closer to this idealized group prototype. Now, for me, what that means is as we work with this model with the group as a whole of group phenomena, the group has a power. It amplifies the contributions of those of us that contribute individually, takes those individual contributions and it transcends them. It mixes them together and amplifies them so that it has this kind of enhancing effect on reflection, but it also can have a enhancing effect on other things, including empathy. And that it helps the group through the dialectic to have this shared understanding of what this is the normative function, what might be the norm for nurses working in ICU in this particular work environment at this particular hospital, which may be similar to but very different than nurses working a pediatric unit in a metropolitan hospital. And this sense of universality is specific to that particular workplace. So this is a further breakdown of the personal and job resources that we found were correlated with reflective practice groups. And I want to touch on this because I find this quite exciting. Having said that, we have to be very cautious when we interpret these as results as well, because once again, we can't prove them to be causative. This is a cross-sectional study. It's not a longitudinal study. But I'm just going to run through them with you. Okay, so the Cseq is the tool we're using to evaluate the effectiveness of reflective practice groups. And what we found is that high ratings, so those nurses that said these groups are really good for me, was correlated with increased personal and job resources of self-efficacy, job autonomy, skill discretion, job social support and cohesion. The total effect, so just going to the group, was significant for burnout and compassion satisfaction. So those who went to more groups had less symptoms of burnout and more evidence of compassion satisfaction. And they were mediated by all of those above personal and job resources. With secondary traumatic stress, however, there was some evidence that group cohesion, this sense of increased group cohesion, was somehow correlated with an increase in secondary traumatic stress. I think this was really interesting, and in the next study we wanted to analyse that more. Was it that those nurses who were in the group and able to listen to their colleagues disclosing more openly about how they felt were then, and had empathy for them, were then affected in some way, and there was a secondary traumatic stress from that? Was it that as nurses became more comfortable, they became more aware of their secondary traumatic stress, which they hadn't been before? Or was it that nurses who had higher levels of secondary traumatic stress actually appreciated the cohesion of the groups more. So in this next study, and this one's still, so these previous studies have already been published in the Australian Journal of Advanced Nursing. And this study, which is looking at secondary traumatic stress, is currently under peer review for that same journal. What we found is that there was a correlation between nurses who wanted to attend the groups as much as possible and higher secondary traumatic stress, whereas those that just attended when I needed to attend them had lower secondary traumatic stress. On the other side of the coin, nurses who attended fewer groups had much higher secondary traumatic stress than those who went to a lot of groups. So for me, what this is indicating is that possibly that nurses really value, and this is what many other researchers have found in looking at clinical supervision and particularly group clinical supervision, that the first benefits nurses get is the restorative supported benefit. So those nurses who are really experiencing a lot of stress and psychological distress, secondary traumatic stress, really value the groups and want to go as much as possible. After a period of time, when they've been going for a long period of time, that level of secondary traumatic stress and psychological stress may be decreased. The current research project we're working on is to try and look at how this all might apply in practice. So we're looking at the benefits of reflective practice groups against the Nursing Midwifery Board standards. And we're finding that there is some correlation. I don't want to preempt too much of that, but that we do have some clear evidence, I think, that there's a normative element there. But I'm going to qualify that by going back to what I mean by normative, and that is to consider the relational aspects, the interpersonal aspects of clinical practice, the value of what we know, many of us know, as one of the great predictors of a positive outcome, which is the Therapeutic Alliance. The Therapeutic Alliance, which is so important in these reflective practice groups, and it's so important in clinical supervision and it's so important in psychotherapy, I'm proposing, is so important in general healthcare. So what we're doing here is normalising that. But don't take my word for it. The next clip I'm going to show you is some testimonies from a range of nurses, doctors, and allied health professionals who have been involved in reflective practice groups. And after that, I'll take questions.
Hi, I'm Danny. I'm the clinical coach on a surgical ward. I have been going to reflective practice sessions for a few years now, and I have just come to really appreciate them. It gives us an opportunity to sit down, take a breather away from that clinical setting, and just have the opportunity to realise that we're not alone in how we feel or some of the things that we go through. And we don't necessarily find solutions, but at the end of it, it somehow makes us feel better.
For the past 10 years or so, I've been involved in the reflective practice groups in mental health. A safe space for staff to go and talk and share clinical experiences with each other, where we can come together and hear what other staff are thinking and feeling, and quite often it's the same stuff that we're thinking and feeling. So it normalises our experiences that we're actually having, and we're able to share our experiences. It allows us to integrate our team as well, so that we can work together as a better team, so as we get to know each other in that safe, protected space.
An opportunity to come together with trusted colleagues and share our experiences and talk about what's happening for us, that we have that opportunity to stop, reflect on what's happening, understand where each other are at, support each other through any of the challenges, and that this has been a huge benefit from both a work perspective and a personal perspective, and I couldn't live without it.
Reflective practice group is an opportunity to sit down with my colleagues and voice concerns that are affecting me as a doctor and my relationship with my patients, and to allow a safe environment to discuss those issues in our day-to-day practice that impact on us as people, and to provide support for my colleagues and help them also to work through some of those issues that are affecting their practice.
I really value our reflective practice group so very much. It provides a platform for us to discuss really complex patient cases and potentially issues that we're working through within our team, and we've seen so much value in that.
It's that space where I can come together with my colleagues and reflect on what's happening in both my work and my personal life and how that's affecting me at work and how I might manage certain situations at work. I think the benefits of a reflective practice group are immense. It gives you that space to reflect on your time at work that I've never had before, and it also helps me to understand what my colleagues are going through as well, and it makes you feel, I think, less alone.
And I really love and value this time and space I get to share with the staff. I really love how reflective practice honors the person within the nurse.
It's really about me time for the individual clinician. It's about reflecting on daily practice and really thinking about how your role is affected by others and how you can affect others in the practice as well.
I thought it was a debriefing session, but I've found through the experience that it's a lot more than that. It is support. It allows framing theoretical basis for what I'm feeling and how I can deal with that. And I think it's incredibly beneficial both to my work and my personal life.
The added bonus, I guess, is that it helps to build a good team environment where we feel comfortable discussing some of these issues with our colleagues and within our team, and I think it creates a better working environment.
It's a great opportunity to discuss, I guess, complex issues that nurses are having, whether it's management or whether it's clinical. We have an opportunity just to voice those concerns and often throw it out to other members of the team to hopefully find a solution or just to validate our experience.
Hi, my name's Amanda. I'm an enrolled nurse on a surgical ward. I have had 2 reflective practice sessions so far, and I find that they're really helpful, especially as a new nurse. Everything is very overwhelming and it's really easy to feel alone and unsure. And these practices have absolutely made me feel more comfortable with my peers and be able to reflect and share my experiences and hear others as well, and know that they're more experienced but also feeling very similar to me, and it is very reassuring and definitely helps me to develop my nursing skills.
So I'll just leave it at that, and just keeping in mind what we were talking about the formative, normative and restorative benefits in regards to those statements or declarations about people's experience in the groups.
Chris, look, thank you very much. I know you mentioned a particular book on this topic prior, but I'd like to also just say that it's lovely to hear you speak both from the head and the heart about this, and that came through very strongly. And for the research that you're doing on something that you obviously strongly believe in because you've seen it work, that just adds, I guess, benefit for all of us. I don't know if you've been able to track some of the, just to flag a few comments that have come through firstly. Such a lovely description of the alliance model, the Proctor model, the one that you just referred to then as well, with those kind of 3 different elements to it. And also a comment from somebody you may know, Brian, who is just wanting to thank you. He perceives the reflective practice group as his therapeutic fight club. I think that's a lovely kind of expression there. A place where it helps him to feel sane, brings people together and makes them stronger as a group. So some really nice comments there from people who obviously are benefiting from the work and for the advocacy that you've been making in relation to this particular important element of ongoing professional work and development. So a couple of questions just to raise, maybe some easier one, some ones that we can cover first. Are you aware of any reflective practice groups that are available online at the moment that might be sort of cross HHS or cross services?
A few, but not many. And one of the reasons for me is that this particular type of model really lends itself, I think, more to face-to-face groups. But in the current climate, I'd run a group for nurses who work in a COVID ward, and we're able to use that medium fairly successfully. There are different applications. I think this Zoom application that you're using is the best one in my experience for reflective practice groups, but that's not always it's not always approved in all health services. But I'm aware that there are others that are providing clinical supervision. I do individual supervision over video, but in terms of groups, there's a limit, I think, personally. So I'm not ruling it out, but I'm saying that there's something that's lost, and I'm not aware of any that are running currently that are more inclusive for those who want to sort of, I guess, apply to join them.
Sure, no, thank you. There was a question that came through about, does Insight provide training in reflective practice group? I can answer that and say, no, not currently. I am aware that QCMHL offers a 3 sort of stage supervision training, but it's not necessarily in reflective. It starts with a sort of a best practice model section, and then being a supervisor module, and then also a supervisor of supervisors. But Chris, are you aware of any training? I mean, obviously you provide that within your HHS. Are you aware of any sort of formal training or training pathways?
Yes, I am. If people want to approach me, I can advise them or guide them towards options or opportunities for that sort of thing. But yeah, at the moment here in this situation, I'm focusing on what we're doing within our health service. But I work some of my time. I don't work full time for the health service. I also work in private practice. But I think that at the moment, there are some interesting and really useful training programs being developed in individual supervision. And I recommend for anyone who hasn't had experience that they undertake them first before thinking about the group modality.
Sure, understood. So
I know that the Office of the Chief Nurse and Midwife has got a project going now with Kathy Boyle and Kobe Hatch that is around basic training, basic but comprehensive training and clinical supervision for nurses and midwives. So that's useful. And I know that the Cunningham Centre, QCMHL, have training programs. In terms of the group modality, I'm happy if people are really interested to contact me, and I can advise them of options. But it's still, it's evolving.
Okay, excellent. And for those you mentioned, as I mentioned, the QCMHL, I'm just popping in the chat a link to their course catalogue for anybody that wants to explore that. And in terms, Chris, I don't know if you can pop in the chat the best contact for you if people did want to follow that up, if you're happy to provide that, or we can send that out afterwards. So we'll make that available on our website. I'll leave that up to you in regards to that. So yeah, no, look, on that, I guess we've got some other questions just coming through, but I'll just refer to some of the ones that came through earlier. So you mentioned about, I'm just wondering, just sort of this question that came through about, have you found in your experience that this fits more in, say, a community health or a community agency model better than, say, hospital or inpatient based? Or how have you, if so, have you any suggestions about overcoming some of the barriers that might come with shift work and ward kind of situations?
Yes, look, I feel that this model can be useful or applicable in any setting. I started off as a model that was specifically designed for nurses who work shift work. That's why we use this group as a whole approach, and that's why we developed that particular model. And so I've run groups, some of my longest running groups, I've been running some groups now for well over 10 years, and they're all in busy hospital wards, which do shift work. But not all staff come to the groups. And I think that this is that important balance. There are some wards where almost all staff come, but some that don't. And I think for me, there's two elements to that. And someone I noticed in the chat, Julie Sharek, asked, is it that people who really value reflective practice and clinical supervision come, and that's why they're so successful? Partly that's the truth. I think that, sometimes those that most need it are least likely to come. But what I've found with this group as a whole approach is that there's a kind of word of mouth. There's this kind of sense of, okay, look, I might come along and just sit there for a while, and we allow people to do that and not actually contribute for a while. And after a while, they start to become more comfortable. And so there is a transformation that you see happening within individuals and in the workplace.
Yes, understood. Yes, and thanks for addressing that question of Julie there. And I'd also just to point out that Julie has sent in the chat to a reminder about position statements for nurses and midwives. I'm assuming that's those for within Queensland Health, on supervision, and also the role development model training. I guess other options there. Lots of comments here, Chris, about a great session. Some people are needing to head off, but just if you've got a few more moments, and if anyone can stick around for us, because we're not quite at 11 yet, so we're doing very well.
Can I just say, James, the role development model is a model which is being adopted in nursing and midwifery, particularly midwifery, and that it has a number of training opportunities as well. And if people are interested in that model, it's another model, but it's another very good model, and it does individual and group elements to it. So there's a training model there. And the other thing I think Julie was mentioning, the position statement is the national position statement that I spoke about earlier. Yeah,
sure. No, thank you. Got a question here as well to you, Chris, about any cultural supervision or cultural RPG. Is that something that you've seen or researched, or is on the ground that you're aware of?
We have had some of our Aboriginal and Torres Strait Islander hospital liaison officers complete our reflective practice group training to gain a greater understanding. I am doing some work with the World Wellness Group, based down in Metro South, which is around, the cultural implications or considerations. I am not proposing this in any particular culturally attuned way, other than the culture of healthcare. So the short answer for that is no, but the longer answer is that I think that this is adaptable and that those sort of considerations can be worked in this model, because it is an organic model which works on a set of principles and not necessarily hard, fast rules. And I think that lends itself towards adaptation to different cultural contexts.
Sure.
As to different work contexts.
Sure, those elements you spoke about really suggested it's a very relational model.
Yes.
So that would fit that very well. I know anyone listening to you today would maybe sort of, if they had any of these ideas, you certainly, I think, helped to address them. But for a lot of people, sometimes supervision is seen as a bit potentially scary, because they're basically needing to make themselves vulnerable. Are you able to give any examples of those structured, reflected processes or practices that you mentioned that might go on in a group, just to kind of give people a little bit of a, sort of peek behind the curtain?
Yeah, so often as a facilitator, I will try to sort of step back a bit with what it's like analysis called hovering attentiveness, looking at both how the group might be processing things, what this kind of vibe is, or the non-verbal sort of going on, and I'll pick up on them, and I'll acknowledge and make space for them to come out, because often in groups there are certain people that are quite dominant. All right, so by allowing the space, we kind of start to draw different perspectives in from the group, and at that stage then we ask questions like about process in real time. Why is it that there are, such quite disparate views on this? Or isn't it interesting that we all seem to think the same way on this? Why do you think we do? Is it something about us being nurses? Is it something about us doing this? Something about the specialty we get? Or you just ask these sort of questions that prompt reflection on deeper levels. Or I noticed when someone was talking then, there was this kind of real head shaking going on. So you start to draw this out by looking, as you said, in a relational way, with so that the group starts to form this more sort of, I guess, coherent and united sort of dialectic.
Sure. No, thank you for that. That's I guess that really kind of opens it up, and I'm just me myself as being someone who's very sort of strong in the advocate around trauma-informed care. I can see a lot of parallels there. It's about trying to provide an antidote to the things that are actually taking away people's personal and professional resources by offering that sort of support and those restorative experiences. Do you find that the groups, based on that kind of formative, normative, restorative, bit like sort of education, advocacy and support, or accountability and support, do you find that the groups tend to sort of different groups drift towards a larger proportion focused on any of those areas, or is it sort of usually balanced, or that's the facilitator's role, is keeping things balanced?
So part of it is, I think, acknowledging in the longitudinal study that I spoke about, we found that the two groups, the ICU and the oncology group, got different types of benefits from the groups. And I guess part of it is acknowledging or trying to identify where it is that specific work area is and that specific group is in relation to their development and what may be most helpful for them. So often a group will really focus on the restorative benefits initially, but some groups where there's already a strong sense of trust and cohesion with the workplace might move on to the sort of more formative elements of clinical supervision. So yes, they can be different. And I guess for me, it's about, as a facilitator or for the facilitators, that it's about looking at how we engage with them at that level. It's kind of a bit like the motivational interviewing approach, that you can come in and say, this is what you should be doing, but about finding what level they're at that particular stage and helping them to work and progress through the subsequent levels.
Yeah, very respectful approach, which usually gets people on board far more than some of those other ways of doing that. Look, I guess we're coming up to our time. I just want to reflect here, if it's okay, Chris, and just try and represent a few comments that have come through sort of thick and fast. So I'm not great at watching 5 things, but you might be seeing it. But really want to just note Thomas, who has found the insights that you've given very valuable. He's very happy for you to make contact, or to be able to maybe contact to start a conversation about cultural capacity and a place-based learning around reflective practice groups. So Thomas, Chris has kindly put his mobile into the chat. We'll send that out to everybody because at the moment it's just to the hosts and panelists. So my capable support here, Niall, will do that. So that you can get in contact. And Julie has kindly put in links to the chat there for anyone who's interested around the position statement and also the clinical supervision role development links as well. So yeah, and lots of comments. So that number has there gone for anyone who wants to contact Chris to have those conversations, whether it be about the cultural capacity or I guess just the early steps in building this as a tool and a support function within your area of practice. Brilliant. Chris, any closing comments from you? The artwork behind you is amazing. Is for anything that you can explain about that as we bring things to a close?
Yes, I'm seated in the antenatal clinic, which is where I normally work on a Wednesday as part of my role as a consult liaison nurse. And this wonderful mural behind me was done by the students at Meriden State College, which is one of the local high schools. And it's really great picture of either Mother Nature or Gaia or the tree of life, or just this great, fruitful reminder for me of the importance of life. And I think I was saying to you earlier, James, that that this work I do here and this clinical work, the therapy I do in this room is some of my most rewarding. And I run a mindful mums group, mindfulness group for pregnant women, which is extremely rewarding. And so once again, I guess it's just demonstrating the importance of that relational approach to healthcare.